Oh my God. You're live.
Alright guys, we might make a start in a second here, so take your seats if there's any left, but we'll get started very shortly. So for those of you who do not know, my name is Max and this is Garnett and we are the directors here at West Coast Veterinary Hospital. It's fantastic to see everyone along this evening for one of our many and hopefully more information evenings. So We'll start off with Caitlin here, who's going to give a bit of an introduction and run through a couple of things for this evening.
Hi guys. Firstly, I'd like to introduce all our trade stands because they are big supporters of our hospitals. So we do urge you to go and have a chat to those guys. I'm just going to quickly run through because a lot of them have got promos for tonight. Stock fees $17.50 for the open rough cut calf, and their shandies $20. So go and see them by a voucher. You can go and pick it up in store. In terms of our hospital, we've got 20% off all our first aid supplies. So if you duck around the corner, you can stock up on all your supplies there. Luke has joined us in South Australia with Inside Out, a great intestinal health supplement for your horses. They're $60 for the kilo bag. Beth from Ram Lab has got a ton of really cool free hats, so go and see her. WA Horse Council enter their raffle, and you can also subscribe to Hoofbeats magazine tonight. We'd also like to thank and welcome Bayer for all the giveaway prizes we have. And Passing Paws. Now they've got $200 off any extra information if they're happy to go and have a chat to you around the corner about that a bit more. And lastly, the Complete Building, who built our wonderful hospital and all our barn out in the back. His dad's here, my father. Happy to chat to anyone that has any queries about that sort of stuff. He's happy to pick your brain. So, start off tonight, we're going to discuss colic. We're then going to have a brief break. Everyone can grab some pizza and some cold drinks. We'll then move on to wounds. We've got some hand-on activities with our little blue horse over here. He's not feeling so great. We'll then have another short break. We can go and chat to the guys around the corner, and then we'll finish the evening off with ice. So hopefully,
Kate's currently doing a carving and/or cesarean, so she should make it pretty.
Hopefully, she makes it that.
Yeah.
We're also live on YouTube tonight, so we'll discuss that a bit later on, so you can join up and subscribe to our channel. So give her a wave to our YouTube channel, and we'll kick off with Matt.
Thank you very much. You're going to work. Right, and just to let you know, if you do subscribe to the YouTube channel, you can grab a free pizza here at the end of the night.
And now, Max and I both can ask some questions of the audience to try and keep it a bit interactive. We've got a lovely collection of freebies and things to give away. So there is a benefit to answering questions, right? So this is an enormous box of tea here. So this one's going to be pretty popular, and some other great sort of prizes. And we'll go through the lucky door prize and things at some point as well.
Yeah.
All right, let's do it.
So feel free to shout out questions, guys. This is very informal. If you have any just spur of the moment things, just yell out and we'll go from there. So this evening I'm going to be talking about colic. So if you don't know me, my background is I'm a specialist surgeon. I'm one of only a few here in Western Australia. And we at the hospital here see a very, very large array of everything. So the most colics we ever see are medical things. So these are things that respond well to anti-inflammatories and are just spasmodic or impactions. But we do also get the very bad ones that are surgical. And you might see one horse over there that had colic surgery yesterday. He's still in hospital on fluids, so you can peek your head over there later. But we do offer all those services here as well. So we'll start off with a little video here. Some people may not have seen a horse with colic before. Now, this horse here, it's showing some signs of colic. It's pouring, so it's restless. The other thing you might note is that it's got all the shavings and stuff on its back, so it's been lying down and rolling. A normal horse, if they do not have colic and just been laying down, they always hop back up and dust themselves off. Generally, a horse with colic or showing pain doesn't do that. It's pouring again, and it's even stretching out a little. So they're all typical signs of colic. Now, in the grand scheme of things, this would be mild signs. The pouring, maybe lying down, getting up and down occasionally. You do see very bad ones where they're rolling or just uncontrollably painful. And they're the more severe ones. Now, the degree of pain sometimes might be indicative of how bad the colic is, but sometimes it isn't. So you just got to sort of weigh things up and go through a systematic approach to every colic. So colic is just abdominal pain. There can literally be about 100 different reasons. Very commonly in Western Australia, people assume it's sand every time. That is definitely not the case. The most common colic we ever see is a spasmodic colic, and that's when they just have sort of gut cramping, like you've been over to Bali and got a bit sick. That's the more common type of colic. And those horses can be really painful. They might be rolling and getting up and down and very uncomfortable, but they resolve very quickly and they respond well to medical management. So why does colic cause pain? A lot of people ask me that. One might be to do with the distension of the bowel, so that means the swelling of the intestines. So a gassy colic is really painful because of the stretching of the lumen of the bowel there. They might be tugging of all the mesentery. So if you go look at Zinzan over there later, how all the intestines type material called mesentery. And sometimes when the intestines are really weighed down, for example, say if they do have sand colic, it's not up along their neck at the top there, it goes down quite a bit. That's a very big misconception, so check that out too. And the other reason why they're quite painful and sick, sometimes you get this ischemia or you actually get dead bowel. That makes them really painful and sick. Hopefully you never have to see that, but that is what happens when they get quite sick and very complicated. So the most common things we see is medical colic, so ones that respond to pain relief and drenching and all that type of stuff. So what do we generally see? We see a sort of low-grade pain. So that means they might be pouring a little bit, they might be lying down. They're not too bad. They're not rolling and or beating themselves off the wall. It might be intermittent, so they might colic for a bit, not again for an hour, and then it's just a bit hit and miss like that. While very severe colic, they won't stop. No matter you give them all the drugs in the world, if they have a bad surgical colic, they will still be throwing themselves on the floor. You could give them 50 mils of phenidine, 20 mils of xylazine, tomonine, it won't make a difference. And this is the other big thing. Are they responsive to analgesics? And I'll get into this very shortly. If you have a colic and, a lot of people have access to phenidine or bute or Metacam, those kind of drugs, they're all very similar, if you didn't know that, but we'll go into that in a little bit. If they have an initial dose of pain relief and they become colicky again in a short time later, you have to really think, is there something else going on? If you're giving them multiple doses of these drugs, you might just be masking something more sinister. And it's very important with colic, if you get in there early, treat them correctly, or even say take them to surgery, you get a very good prognosis. Well, if you just keep doping them up with drugs, that's when you end up with dead bowels, dead horse, and a bit of a disaster going on. Other things you'll see with medical colics, you might see there might be a change in fecal output. They might have diarrhea, which would be a sign of colic. Very commonly in Western Australia, you'll get sand colic, and they'll actually have diarrhea because of the sand. Because all the sand sits at the bottom and all the fluid parts at the top, so they'll actually get sort of a runny type feces. So that'll be very common with sand colic. If they do have a colic due to a bacterial infection, they might actually get full-blown diarrhea, like a salmonella. And other times, if they have an impaction or other things happening, they might actually, have a really hard feces that isn't coming through properly. Other things to look through in the feces is, there might be worms or something present, or even abnormal content. One very common thing people say, they have worms in their feces, but you get all this white mucus through there. The white mucus in the feces is actually feces that have been sitting there for quite a while, and it's all the bowel secretion. So that might be more indicative of a displacement or something like that. So your treatment objectives when you're managing a medical colic, so not a surgical one, is we want to give them pain relief. Now that's you don't want to mask things, but you need to make them comfortable so they can respond to it. And once again, let's avoid the strong medications. They might even need sedation to start with, and these are all veterinary things. Prevent the horse from injuring itself in the immediate time there, and we'll talk about some things about walking and whatnot shortly. And we want to restore normal function of the digestive system. So that might mean actually giving them the medications. We may need to tube them, or you may even need to flush them out, or get rid of the sand. And there's many different ways to do that, and we'll chat about that shortly. Like oak stock feeds have a lot of stuff here, like sand flush and whatnot. It's all based on psyllium husk and metamucil, but there's all many things you can do with that. So we'll talk about treatment shortly. Now, controlling pain, I thought, these are veterinary drugs, a lot of these things, but I just mention them because a lot of people do ask or may have access to some of them. Phenidine is probably the next to mebulamide, is the most common drug you'll ever use when treating colic. That's a non-steroidal anti-inflammatory, or NSAID. It is very, 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 very similar to bute. So phenidine and bute can be interchanged. They're pretty much the same drug. However, people get really obsessed with using one for other. If you're in the UK, pretty much all colics you use phenidine to start with anyway. But phenidine and bute are very similar. But be careful, because these, if you overuse them, and I'll show you what might happen, it can actually cause a different type of colic called right dorsal colitis. And these are these real hindgut ulcers that horses die of, and I'll show you what they look like shortly. Then you might use opioids. A big one is buscopan, the same stuff we have as humans, buscopan. This is a very good antispasmodic. So if you have a spasm colic, one that's cramping a lot, buscopan is the way to go. That's the best drug for it. And we may even tube them or give them sedation. The tubing is to decrease pressure off the stomach, because horses can't really vomit easily. If you have a horse that's vomiting and they're spontaneously refluxing, that's very bad. But they can do it, but it's usually a bad sign. So, common questions here. Should I walk the horse? Should I not walk it? There's the walking. We do encourage sometimes. The main thing is so the horse doesn't himself. They are not, by rolling, so to say, they're not going to retwist their bowel, or usually untwist it, but it will stop them from hurting themselves and maybe get them in a position where things aren't going so well. Also, walking or putting them on a float ride, sometimes by doing that, it does distract them quite a bit, and if they aren't that painful, it may actually just resolve it by taking their mind off it. So there are two reasons for doing that. Some people even lunge them if they have a mild displacement or a spasmodic type thing. Sometimes lunging them might help, and a very common condition we get where they do have a mild displacement or a left dorsal displacement. Lunging them does help sometimes, so we can do that. Generally don't let them roll, mainly so they don't hurt themselves, but like I said, some people say they might retwist or something. That's not really the case, but it's to stop injuring themselves. And should they have food? Generally not. Food does help promote, like it's probably you have a cup of coffee or something in the morning, go, I need to go to the toilet now. That does help in some respect. It's got the gastrocolic colic reflex when you do pass along like that, but generally we don't let them have any food until we know exactly what's going on. This is the second most common type of colic, is a pelvic flexor impaction. Now these are all sand colics and everything, and that's why I bring it up now. That's when they get it all pulled in the back part of their intestine, the large colon, and it becomes this solid mass. So the mainstay of treatment of these is the pain relief, as we discussed, and we want to really get a lot of fluid into their bowels. So that might be either by tubing, and we can give them, electrolytes, oil, magnesium sulfate, any mixture you want there, electrolytes. And we sometimes give them additional IV intravenous fluid therapy to help supervise and get everything moving through. And that fixes the vast majority of pelvic flexor infections. we always try and treat these medically to start with. Like I said, we've got the pain relief up there, and we just want to keep checking. As soon as they start passing feces again, or they feel good rectally, you know you've resolved it. This is a big question, like should I be regularly drenching my horse with oil, paraffin oil? We can have a bit more of a discussion on this in a bit, but Amelia's made up a little bit of a thing over in the, is it over in the crush over there later? We go have a look later when you grab some pizza, but you'll see fecal balls that have been suspended in, you know, paraffin oil all day. They stay as fecal balls, it preserves them. It doesn't really break it up. What the oil might do is help lubricate the intestines a little bit to get things moving, but honestly, the best way to solve impactions and get things moving through is by super hydrating with fluid, electrolytes, and even some magnesium sulfate, which draws water into the intestine. So oil can't help, it might help a bit, but there are many other ways to get things moving through the intestines there with those type of things. Now, I just wanted to bring this up once again. Too many NSAIDs or bute or phenidine can cause this, right dorsal colitis. These horses present with colic as well. So once again, another cause of colic. So you might treat one type of colic and get another, which is much, much worse. This disease can be very fatal as well. And when you are giving this, you know, you might be giving it for an eye injury or a poof abscess. If you give like a horse, for example, 20 mils of bute once a day for, you know, 3 weeks, will probably kill it. But if you give 5 mils one day for its life, it might be all right. So it's a very fine line, these drugs. And this is what happens when you get a right dorsal colitis. So these are true hindgut ulcers. When you have this thickened colon, the bowel necroses, and like this horse obviously did not make it. And it's pretty much irreversible if it gets this bad. Most of them die. So be very, very careful using too much bute or phenidine or those NSAID type drugs. Right, first question to the audience. What's in this species, guys? No, not worms. Sand. All right, there's a prize. You get this first one. There you go. Good job. Yes, there's sand all through this species. Now, this is a very obvious one where you've got sand going through it. You can do sand tests of feces. If you don't know how to do that, ask any of the staff here, any of the nurses, vets, they'll show you how to do it. It is literally a 10-second test you can do at home and it costs you nothing. And you can actually see the sand or pull at the bottom of a glove or a shopping bag once you mix it with water. And you can actually see there's a large degree of sand in the feces. So sand testing is a good thing, but it's not always definitive, but it might help. So sand colic, what causes it? It is generally horses, you do get horses that are a bit silly and like eating sand. They do get that. It's a stereotypy and they just get addicted to eating sand. They're weird. You get other horses that will pick it up in their feed. So if you throw all their feed on a very sandy ground, they'll just pick it up and guts on it and they'll eat the sand at the same time. And other horses might just be really hungry and be eating very short grass, and then they'll pick up all the sand through that as well. So there's a few different types of ways they can get sand colic. Occasionally, if they have odd mineral deficiencies, they can decide that they want to eat sand as well. So they're all things that may cause sand colic. And how does sand colic cause problems? Well, it causes the irritation, like the grain scraping against the mucosa of the intestine. That's why they get the diarrhea and they get uncomfortable, and then they get these massive impactions. Like, I don't know if we have, like, there's many a horse we've had in on the table here where we've pulled out, I'm not even joking, not 1 but 2 really bins worth of sand. That's how much sand they can get in there. And if you have a look at Zindan, like how big the intestines are, you'll see why shortly. So once again, sand colic, prevent access to it. We can give them medications to help with the pain. We want to try and get rid of the stuff in the intestine. So that's when you talk about sand drenching. So that might be, you know, the paraffin oil to a degree, the magnesium sulfate, the electrolytes. A very, very big one, and all these studies in the world that have done this, the best way to get rid of sand is, you know, more of a prevention type treatment is with either bran type diets or psyllium husk, aka Metamucil, the same stuff people take. If you want to see any of those type of products, once again, open stock feeds have a heap of them there. It is something everyone should consider in Western Australia if you've got a very sandy property. There are many different ways to treat this, but generally you feed them at a couple of days each month, so you can give them a sand flush and make them eat these things. So if you need to chat to anyone about that, chat to some of the vets or nurses here and we can give you some more advice. So that is generally the best way to stop sand colic from happening. Drenching helps some horses, but it's not 100% protective either, just to let you know. And we'll chat about that. So, any quick questions about medical colic, guys, before we go into some more things that are more serious? Just yell out if you have any anyway. So what happens if your horse, you treat them all this way, they get worse, they start pouring, rolling, they're very uncomfortable. What might this indicate? So it might mean there is a surgical problem in there. When we are initially assessing a horse, I don't know, some of you might have been here and I have the same line. What we need to work out now is this a medical college or something more sinister like a surgical thing? And we try and put all the pieces of the puzzle together. So how many doses of pain relief have they had? What's their heart rate? How painful are they? Do they have gut sounds? Can I feel anything bad in their rectally? We pop the ultrasound on, check for any dilated loops of intestine, which might need a strangulating lesion. And we also check for, you know, if they're vomiting and anything else, we might take blood-wise. So these are all things we check for if we're deciding whether there might be a surgical thing. This is called a peritoneal tap. So their abdomen, all their intestines in there are bathed in something called peritoneal fluid. And it's very good to get an assessment of this sometimes if we're not sure, because it might indicate whether it is sort of a normal colour, something that's very bad and possibly infectious, like a peritonitis, or these are all degrees of, you know, there might be some type of strangulation in there with the fluid and whatnot leaking from the bowels into the abdomen. So these are additional assessments we might do.
What's their normal resting heart rate?
It depends on the horse, but it should be between about 30 to 44. A really fit thoroughbred or standardbred might even have a heart rate of 24 or an endurance horse, an Arab. If generally no horse's resting heart rate is greater than 44 unless they're stirred up. So if you've got a heart rate getting into the 50s or 60s, yeah, maybe it's mild, maybe it's more severe. If they're up in the 70s or 80s, there's probably a bigger problem. Yeah. They're all quite good things, like general horse owners you should know. And, you know, if you want to learn how to take a heart rate, we can show you how to do all those things and whatnot. And once again, like, even having a little first aid kit with, you know, thermometers and, you know, a stethoscope, or even a little basic one, you can get heart rates. And if you take your horse's heart rate and go, it's 36, you know, you can sleep a bit easier, while if it's 80, it's like, call it that. Yeah. If you haven't ever seen a horse get put onto the table or anaesthetized, I thought we'd just show this video. This is the horse we had in here. It's not going for colic surgery, but you have to give them sedation to start with, and this is one of these padded induction rooms just beside you here, where open stock feeds and passing cords have set up. We give them the sedation, then we induce them with something like ketamine or diazepam. Then we have a big team here. The horse will be intubated, so an endotracheal tube to help them breathe. We then hoist them up on a device like this, and we take them through into surgery. So, and then they can get placed on this special hydraulic table and put into whatever position you want to there. So you can go into on their back for colic surgery, or, you know, whatever, do a surgery on them. So that's quite interesting if you've never seen that happen before. in here is our surgical theatre. Have a peek in there and you can see what it all looks like in person there. Right, next question. This is very bad looking intestine. These are my gloves, obviously. This is all sort of that dilated small intestine that shouldn't be like this. This is all dead intestine. It's off coloured. Can anyone tell me what this is? The core. This little tiny thing is the cause of all this problem. Sorry? It is. It's something called a lipoma. So these are very common in older horses and or ponies. There you go. I might have some description as I'm present there. So these are lipomas. They cause it strangulating lipoma. Doesn't have to be a fat horse. Like it is a fatty lump, but it's just part of that mesentery thing again. And this will have a little stalk on it, and it just wraps itself around the intestines. They are very, very deadly little things, but they're unfortunately very common. So that's called a strangulating lipoma. This is what it looks like when I was talking about the large colon on a horse. This is one I did the other day. And this large colon isn't quite sitting in the right position, so it was a displacement that isn't responding to, like I think we'd had it in the hospital for quite a while. And you see how big the intestine is. Now this isn't that dilated, so it's, probably, they get twice the size of this, but you can see it takes 2 people to get it out, and it's pretty big. Now, I'll play that again, because you can see in a second, when we get this bit of the large colon, you can see it's large there, it's actually quite swollen and bruised in the middle of it here. And if this had gone on too much longer, they get a dead intestine. And that's when you have the disasters of colic surgery. If you get in here and correct this before things die, things go well. And look down here in a second, see this is all discoloured down there. Sorry, it cut off shortly, but if you get in there early, that's what you don't have problems. One other thing, worm your horses. Even if you're doing it every, say, 3 or 4 months, depending on your system. If you think your horse still might have worms, they might do, because worms these days are becoming quite resistant to a lot of the common wormers we have. So you can do fecal egg counts and actually test whether they are eggs in the feces. So, you can always just drop off a sample here and we can test it for you. It's easy to do. This is when you have a worm infection. And these are very commonly, once again, surgical lesions that can be prevented. And as you can probably see, like the whole small intestine, this is one of them, is packed full of these worms. And they get very sick of these, and even if you do worm them, once they get to this stage, it's all getting too late. So I thought I'd just show you that's why you worm your horses, because they get colic because of that.
What worms are they?
They're called ascarids. Your general normal horse wormers will cover that. If you want to check, these are the wordings of that specific one, Parascaris equorum. Sometimes the wormers will specifically say if they do that worm or not. So that's one thing to check for. And once again, I said, you may even need to do surgery to get these worms out because they're disasters.
Is your fecal egg count accurate for all wounds that they carry?
It is relatively accurate. You have to get, it's just a sample of what's happening in the whole intestine there. Generally, if they have no worms in their feces, there's not going to be other worms that are hidden. If they've got a moderate to high worm burden, there's probably got many different worms and not just one. Yeah.
That's a good related question. A lot of people, including myself, have had hot fly trouble recently.
Yeah.
And I wondered, I'm seeing photos of spots coming out of mouths.
Yep.
When you use a wormer to get rid of what's in the gut, will that deal with the mouth as well?
So the question is about bot flies and worming there, and if they have worm bot fly larvae in their mouth and you worm, generally not. The worms have to go systemically and fix that. It's like on their legs, if they have all the bot fly things, like you've got to knock them off for that to work. The bot flies, like their life cycle goes through their stomach usually, and that's where they attach and go from there. So generally, if you break the life cycle, all those other things will stop, but it won't have an immediate effect on the mouth ones.
So basically, even if we have dealt with the eggs on the leg, wormed the horse, we still need to check them out.
You still should check them out, but like once you break that life cycle, it'll all eventually stop. Bots aren't, in any way bad, in regards to the colic type thing. And a lot of horses will normally have a couple of bots when we do a gastroscope, to check for ulcers and whatnot. There might be a couple of bots there, but it might be completely normal. If you want to have a big conversation about ulcers and all that type of stuff, we can do that later. That could take a whole lecture. There's all gastric protectors. We can have them on, which might help, or probiotics. So if you want to chat to Luke, who's here as well, who's got some probiotics, I can have a bit of a chat to you about that. And we also have a representative here from Randlab who provide a lot of the type of omeprazole treatments and for stomach ulcers and whatnot. So yeah. So those things are very good as well. So she's got free hats. Another cause. Now I'm just going off a couple of little interesting things here, guys, because we don't have all night. Well, we do. You guys will get sick of me before I get to you. But this is why. Should you leave hernias and stuff in foals and horses? No, not really, because this is what happens. This bit of the bowel can get stuck in the hernia, and they get strangulating lesions and can die from these. So be very careful with foals and weanlings with hernias. You should get them fixed because this can happen in some of them. It doesn't happen in all of them, but it happens in some. So be very careful with that. And a hernia surgery is literally about a 20th of the price of any other, type of surgery when it comes to colic. Just so everyone knows, colic surgery these days is a lot more successful than about 10 years ago. With large colon displacements or impactions and things like that, we hope to have 90% back to doing their previous athletic performance. That's a pretty good prognosis. When you have horses that have strangulating lesions of the small intestine that people have sat on for a day, that's when you have these disaster stories of these horses getting really sick, their feet falling off from laminitis and everyone crying. So it's very, very bad and a serious problem. But if you do get in there early, when you know what the problem is, we can commonly fix these things and end up with a good result. And like a lot of these things have improved over the last 10 years or so. A rough price, because everyone will ask me, on a colic surgery, a large colon displacement, probably the easiest one to do. The surgery fee itself is about $5 to $6 grand plus aftercare. Most large colon displacements go home with a bill of maybe $8 to $9 grand. Small intestinal problems or complex ones, they may go up to 9 or 10 or plus. But they're just some rough quotes, don't hold me to them. But, if you do need colic surgery. So I thought I'd just let everyone know sometimes it is actually a little bit more affordable than, you hear of these 20 or 30 grand bills. But yes, it doesn't happen here anyway. Once again, this is what happens if you leave hernias. All the bowel gets stuck in here and, you have to resect everything out, and it's not so great. A quick diversion onto foals, if anyone's a breeder here or have foals. The most common cause of colic in foals, which we'll get to in a second, is a meconium infection. So meconium is the first part of the feces that comes out, which are these really hard little balls, and it commonly gets stuck in there when they're first born. So that's something we'll chat about in a second. But generally a foal, if they're not trying to run away and or kick you or bite you or doing something cheeky, there's something wrong with them, in my opinion. They should be naughty and they should not want to get caught unless they're very well trained. So things you might see is they're off the suck, they're laying down, they're kicking at the abdomen, or they're grinding their teeth. So once again, they're prone to even ulcers and whatnot, and sometimes you need to get them on probiotics or ulcer treatment themselves. So a sick foal with colic is an emergency. You shouldn't wait with them. These little guys are neonates and they don't have the energy reserve like an adult does. So if you are breeding and you have foals with colic, that's a bit more of an immediate attention and just don't wait what happens. This is the passing of the meconium. No one's ever seen it. It's like sheep or goat feces. It's like these really hard black balls. Then the normal foal feces will be a paste that comes out because it's a milk feces. So be aware that they do change their fecal consistency. Once again, meconium impaction, we can feel it digitally, like with our finger, and generally they respond to all medical treatment. You may need to give them an enema, soapy water, a fleet one, and maybe some pain relief. But most of the medical treatments we do for foal meconium impactions go really well. But once again, it's all about early intervention and appropriate treatment, and you get good outcomes with colic. So once again, this is the more normal feces coming through here. And sometimes we even tube these little guys with paraffin oil and or some of the electrolytes and whatnot to get everything moving. So you can tube foals to get everything through. And we commonly actually just tube them with the mum's milk just to get a lot of fluid. Once again, super hydrate the feces there. So a little quick thing on foals. So this is what happens at the end of the colic surgery. So this one's gone quite well. You can see how big the kind of incisions there sometimes on the belly there, and we hoist them back up and take them into the padded recovery rooms, and we assist them in recovery there, and they're all on infrared cameras and whatnot while they recover, so we can keep a very good eye on them. So look, that's a bit of an overview on colic. We've gone everywhere from medical management of foals all to strangulating lipomas. It is just like a basic brush of something here that's a very complex disorder. But like I said, the main thing to remember is if you treat medical colic appropriately early, you generally get a very, very good result. While if you sit on things and wait and keep topping them up with quinidine and don't treat them appropriately, then you might even end up here. But once again, if you do have a surgical colic that isn't responding or it's very severe, if you do get them on the table quick, you end up with a much, much, much better result. So the question there is, does beer ever work? Now, yeah, we drink it, that helps us. It might calm everyone's nerves. Sometimes, generally no, it doesn't do much, but like sometimes I rock up the colics all the time and the smell of beer. Yeah. Sometimes by giving them that, it may, do that thing in their brain and go, oh, what's happening here? I'm not so painful anymore. But no, the beer doesn't really help that much.
The main thing is you never get enough beer in maybe.
Yeah, you have to tube them with the beer. Now I'm not being silly here. There is a condition where they get gastric impactions that cause colic. Sometimes they eat seeds, orange seeds, persimmons, or if anyone knows what they are. The treatment of choice with that is tubing them with Diet Coke. I'm not even joking. Because Diet Coke, how it breaks up things and whatnot and breaks up all the, secretions and bonds. If you have a gastric impaction, we do things like that. So, who thought of that to start with? There's many studies written on that. So there are some bizarre treatments out there. A lot of them do have merit. So, I don't poo-poo these things instantly. But yeah, some have merit, some do not. But the main thing is, know your horse and know what's normal and, seek appropriate advice if you're not happy. And like here at West Coast Vets, like honestly, we pride ourselves. We will pick up the phone 24/7. Anyone that knows us knows we answer no matter what, and you can have our personal numbers. I'll give you Garnett, so I don't care. So if you ever have any questions, like even if what's my horse's heart rate? It's 1 a.m. Garnett will answer. Has anyone got any other questions regarding Colic?
It's not so much a question, but I had that years ago when I lived in England, decades ago. A lot of Jack and Ross's had colic, and somebody suggested whiskey.
Yep.
He got over it and kept coming down with colic afterwards.
Yep.
Turned out we liked whiskey.
Oh, there you go. So they might get addicted to beer or whiskey if you give it to them. So yeah, the vets will keep coming out and keep giving us beer. So like I said, just if you have any questions, there'll be a question and answer session, a bit later. If you have any other things, or if you want to just come find us personally, that's absolutely fine. You can chat to us about anything you want to. So I think, Caitlin, what's the plan now? We got a bit of a food and.
It's got pizza.
So there's pizza guy. Is it intermission now? Or is it an intermission now?
Break for 10 minutes and then
We
I'll.
have a lot of pizza, so we might have to go.
Okay, no worries, guys. So we're going to have a 10-minute break now. There's some food there, pizzas, and there's drinks and whatnot. So
If anyone needs to go to the bathroom, access.
the bathroom's up, mate. Now, guys, if you do get your food and drink, if you walk out that way, keep walking out the door and enter back through the side there, just so everyone goes in one direction. If everyone's trying to fight the flow, it'll be a disaster. So if you want food and drink, walk out the door there and come back around. Alright, we'll get started soon, everybody, so make sure you grab plenty of pizza. We want your stomachs as full as possible for this talk, right? Alright, while we're waiting for everyone to take their seats, what Max has got here is what he was talking about earlier about the demonstration of food that's in paraffin. And look at these beautifully preserved balls of food. They're pristine, aren't they? And over here, food,
same food, same force, but in water. So that's why we love water. We all use paraffin as well, but water achieves so much. So don't discount water.
Yeah, so that's just paraffin, guys. That's the big whatever it takes to see. But basically, I had a really good time last night finding all the best pictures on my phone and the best movies. By best, of course, I mean glorious. So it was really interesting sort of thinking through some of these old wounds and finding these old pictures and sort of remembering how these horses went. And thankfully, most of them went really, really, really well. Not all of them, but most of them went really well. And so we'll talk through some of these cases and things throughout the next 20 minutes. I'll try not to go too much over time. Now, the other thing that I want to mention at this point is when I was going through all my photos and videos and things, I thought, oh, what a shame! All these videos are just kind of languishing on my phone, and we're not really doing anything with them. So we did think, oh, let's create a YouTube channel. So as of yesterday, we actually had a West Coast Vets YouTube channel. And for those of you who are right into YouTube, make sure you seek it out, just type in West Coast Vets in the search bar and subscribe to our channel, because my big plan is that we can stick the really interesting videos and case studies onto our channel so that we can sort of share our adventures with people. So have a look for that. And I think we said that people who subscribe to our channel can have a free beef ear. So I don't know where the beef ears are, but we'll find some, so make sure you take one home for your dog. So a couple of benefits to subscribing to the YouTube channel there. So these are the things that I want to talk through in the next 20 minutes. So my aims are to just really quickly talk about the types of wounds. Then I'm going to talk about how to treat some simple wounds, some not so simple wounds. And then finally, just a couple of comments on getting help. So there's lots of ways to get help, not always vets, but there are lots of people who can help in these sorts of situations as well. All right, and now this is the big warning. These photos and these videos are gory. Some of them are really pretty confronting. There's a few surgeries with scalpel blades. At one point, there's actually a bit of blood that spurts out of the camera. So if you are really not into that sort of thing, don't be too afraid to stand at the back or kind of get in a position where you don't have to watch. But if you do love that sort of thing, then come and watch and get involved. You can probably tell that we do like the really interesting gory stuff. So we like fixing it. All right, that's enough of a warning. If anyone vomits on the ground, we will make fun of you. Maybe get your bag and stuff. Oh, and reminding to give away some stuff. I think Max successfully gave away one thing, two things, a cup and a towel. So we're going to try and give away most of that. I might give away the tea first, hey? I think so. It's a pretty good prize. The whole box of tea there. All right. Now, types of wounds. The reason why I wanted to include this in this talk is because it's really helpful for me when someone can describe their wound over the phone. It's often even better to send a photo, but at the very least, if you can describe a wound in some simple words, it helps me imagine what you're seeing, and then we can decide together what needs to happen, whether you can treat it at home or whether it needs to be seen or whether it needs to come into the clinic straight away. So the first classification I like to talk about is mild, moderate, and severe. And we're going to look at some pictures of wounds in a minute and talk about how to say what's a mild wound, what's a moderate, and what's a severe wound. But it's very much your judgment, and you're going to basically be pretty close to it. Is it contaminated or clean? So a contaminated wound that's full of dirt, or clean if it's just a simple laceration that looks really neat. And what type of wound is it in terms of the result of the injury? So is it an abrasion? Is it a laceration? Is it a puncture? Or is it an avulsion? Ooh, who wants to have a go at telling me what an avulsion is? I reckon this could be our first prize. Yep.
Like out of the skin.
Something that's been pulled away or torn off, right? Oh, do you like tea? Alright, do you like tea? Oh. How about a travel mug?
Yeah, that one.
Cool. Right. I'm not a tea drinker, but I know how much some people really, really love tea. Who are the tea mad people? All right, okay. We'll have a question of the T-man people. All right, the next question is going to be the T-man people. In fact, I know exactly what the question I'm going to use for T-man people, just as a cup of tea in my presentation. So we will use that. All right. Okay, so here's a wound that I went out and saw a couple of months ago. Sorry, both of them were wounds I saw a couple of months ago. These are different wounds, different horses. But I just wanted to show what I would call to be a mild wound versus a moderate wound. And so some of the differences between these pictures are important to talk about. So firstly, does it go through the skin? So this one actually doesn't go all the way through the skin. You can still see the layers of the skin. The skin has several layers, so the epidermis, the dermis, and the hypodermis underneath. When it's always a little bit hard to tell from the photo, but this wound actually doesn't go all the way through. You can't see the structures underneath. You can't see blood vessels, nerves, joints, muscles, tendons, any of that. You just still see the inside of the skin. Whereas this one over here is a much deeper wound. So you see how the edges of the skin have actually pulled apart here? That's not actually bone. That's just a little bit of connective tissue underneath. But nevertheless, it's not skin. And the other big thing about this photo that tells you that it's much more severe, look at the amount of blood. So all of that blood has come out of one of the vessels that runs down on the medial side, so the lateral side of the leg there. And it's quite an important vessel. So that's why we've had so much blood. So is it through the skin is a great thing for you to be able to tell me. I said we had sort of mild and moderate, but this one is obviously a severe wound. So when you tell me my horse has a severe wound, this is what I'm thinking. All right. If I come out and see it, and it's like the picture on the left from before, that's okay. That's okay if you have fear. I won't cry. All right, it'll be fine. Or it's gold. Now, keep in mind, I'm a Queenslander originally. I hear someone go, it's the most popular beer in Australia. I mean, we can't all be that nuts. But anyway, so this is a severe wound, and what we're looking at here is skin that's been torn away, so it's been avulsed. You've got deep lacerations, you've got exposure of several vital structures. I think that's a bit of a nerve or blood vessel that's been torn there too, and blood all over the place. So that is a severe wound. I won't go too much into clean contaminated. That's pretty obvious, you know, it's full of dirt, and then we sort of saw some of the different types of. Everyone knows from that raised video where, you know, we scalp away bruising, so we'll keep going. Now, treatment of simple wounds. I like this picture. I sold this off the internet, but I just thought it was really funny. So horses find so many interesting ways to injure themselves, and sometimes they'll even just be cruel to each other. Look at how unimpressed. All right, now. When we talk about treating wounds, I think it really is important to have a slide in here about safety, because you guys know your horses very well, but they won't necessarily be thinking like their normal selves when they're injured and they're in pain and they're scared. So you need to remember that just because you can normally walk around the back of your horse and pick up its legs and poke it and cut your hands, jump up and down, don't assume that it's the same when your horse is in pain. When you see it bleeding, and holding its leg up, don't just rush in there with the towel thinking that you'll wrap it up or something. Think about your own safety as well. Okay. If you can, find a buddy. So someone who can hold the horse for you so you can examine. So you've got hands free to take photos so you can clean everything up and call the ambulance when you get kicked. Move the horse to a safe area. So if it's somewhere where it's been injured or it's scared, and it's able to walk, then move it somewhere a little bit safer. And one of my favourite things is to move it somewhere where you've got really good lighting, because a lot of these injuries do seem to happen at night. And Max and I will often see us getting around with these ridiculous head torches, because they make such a difference when you're trying to do stuff in a paddock in the middle of night. But one thing even better than that is if you can have your horse somewhere where the lighting is great. All right, so what are you going to do straight away when you realise that your horse is injured? These are the things that you should think about. So Firstly, try and just assess the overall stability of the animal. So, is it injured just because it ran into something, or is it injured because it's rolling from colic? Are there other significant wounds going on? So, just sort of primary survey, figure out the general health of the horse, and then look for all of your other injuries as well. So, it is sometimes really easy to focus on something that's bleeding a lot, but you might miss a stake wound or something on the other side. So, try and not to get too focused on one area. Grab photos. Photos are excellent. If you call me in the middle of the night and want to talk about a wound, I'll give you my number and ask you to send me the photos or send me the videos. Because that's a really, really quick way for me to figure out what's going on. Same in the day, you know, send through photos. Everyone has a smartphone that can take pictures. They are a wonderful tool and we use them all the time. And finally, the last of those initial things that you should do, just protect the wound from further contamination. So I'm not talking about the best bandage in the world, just something, you know, stop the extra dirt, flies, anything else when you get into it, especially if it's really dusty or horrible or you're going to walk through much. Just try and stop it from getting too much further contaminated, and they're sort of the four best things you can do straight away. And then once you've got a chance to think and breathe, you know, then clean it up, have a look at it. If it's a pretty minor wound, then yes, you can bandage it, and we'll talk about some bandaging techniques in a sec. Discuss it with the vet. So as Max said before, we're very contactable. You can always ring up, bring reception. Ideally, bring out mobiles if you've got them and it's urgent. But who has our mobile numbers already? Yeah, we're not precious about it. And then tetanus. Big wounds, think tetanus. Who wants to answer this question? How often should a horse have a tetanus vaccination? This is not the T group, okay? Once a year. That's the correct answer, but it's not necessarily the only answer. Not the town. I think you like it. How about a comp? The dog. It's really interesting. So, animals definitely need tetanus vaccinations, and a primary course for a horse is 2 shots a month apart, ideally when they're a little young. But if you read the manufacturer's recommendations, they'll actually say you need to vaccinate the horse every year. Now, it's not quite true because we know that the tetanus vaccine actually protects the horse for longer than that. And I normally say, well, you know, it's good for at least 2. It's probably good for 3. If you're getting up to 5 years, you're probably risking a bit too much, though. Now, the reason why the manufacturer says 1 year is because when they did the initial study, they proved that the horses were completely protected for a year. And then they just were like, oh, well, the study's given us an interval, that's great. We can talk about vaccines for a very, very long time. And if you have any questions about the intervals of vaccines, then just give us a call. But if you do vaccinate your horse every year, that is a great thing to do. I don't think there are any big significant issues with vaccinated horses or potentially over-vaccinating horses. But you do get away with a little bit longer. And if you've got a wound, you want to make sure your horse has been vaccinated. And tetanus takes a while to happen. So you can have a wound like this. If you sort of focus on getting your horse vaccinated immediately, you can actually offset the development of tetanus in some cases. This is Garnett's 5-second version of a complex question too. So ask me about it later. We'll go a lot beyond.
Can I ask a question?
Yes.
What are the differences in the action between a tetanus vaccination and the antitoxin?
Yes. So the antitoxin actually binds up the tetanus toxin. So whereas the vaccine is what we call tetanus toxoid. So your body goes, oh, tetanus toxoid, you're a bad thing. I'm going to mount an immune response. I'm going to remember you that you're bad. And so that's your immune system doing the cleanup.
So going to be a lot more effective than
Yeah, you want to have a horse that's vaccinated. Now, if you've got a horse that has a really significant wound and doesn't have a good history of vaccination, that's when I can give them the antitoxin as well.
Sorry, just because the tetanus is often with the strangles.
Yep.
I read recently that strangles should be every 6 months.
Yeah, strangles doesn't have a longevity at all. Yeah, and a lot of times it's sort of like, oh yeah, we do it annually, but a lot of studies have shown that you lose a lot of protection after 6 months. So I used to say, if your horse is about to enter into a season of performance or something where it's going to be encountering a lot of new horses, especially, there is the potential for strangles, then vaccinated just prior to going into that. We had a lot more strangles in Queensland, so it's a much bigger issue there.
Can you get strangles on the phone?
Yeah. You buy Tetanus on its own, strangles on its own, and the 2-in-1. But the 2-in-1 is the common one. Yeah. All right. This is a great video. Okay. Some of these are my videos, and some are Max's, and this is one that. As soon as I realised that I was going to do a talk on wounds, I really wanted to get this video in. So, yeah, hold on a Pretty cool. And the coolest part of this video is that Max actually filmed this in advance, which is good because I usually get to this part where I pull the enormous steak out of a horse and go, I wish I'd filmed that. And so it's obviously a horrible thing for that horse, but a very, very interesting video to see, and it's just amazing how they injure themselves. And the point of this slide, apart from just generally showing some gore, that really wasn't the point. If it was to say, do you pull splinters out? Who wants to have a go at answering this one? Who was loudest? I don't even know what to give away. Who wants a sunrise? I think it's a sunrise. I heard someone say no over here first, I think. No. Yeah. Do you want another prize? No, I'm going to give someone else. Who else said no? Sharon. There you go. Okay. If you could leave the minute until you can photograph and at least talk to us, that'd be really good. Now, there are some splinters that will come out in one piece, and others that will leave little bits behind, especially with foot wounds and nails going into feet. Sometimes we'll actually x-ray them before we take the nail out, so we know which structures have been affected. So the ideal thing to do, if you could please ring us before trying to pull it out, we will guide you with what to do.
That would have been stated though.
Where's that? Yeah. What was the story with that one?
It was on the lunch.
Yeah.
Yeah, it just hit the rail as it was being lunged, and it just slid off in there.
Yeah.
So it was like totally sort of accidental type thing. Didn't run through fences, just routine lunging. Yeah.
And that was just pulled off under sedation, wasn't it?
Yeah, just a bit of local and sedation. It was, you could just feel it all the way under the skin. So that's why I said get the camera out. This is going to be cool. And if you ever wonder in advance, if the vet ever says, let's get the camera out and have like a look at this, that usually isn't the best thing.
All right. Okay, so everyone here wants to know how to treat wounds as well. So these are some of Garnett's top tips in treating wounds. So you have some options. What do you clean wounds with? You can clean them with water. Water is good. The cleaner the water, the better. Please don't use the really, really manky water. Betadine's fantastic. Betadine is my favourite thing to clean wounds with. This is betadine concentrate. You do have to dilute it down, which we're going to talk about on the next slide. You can use things like sodium chloride, so this is sterile wound irrigation solution, which is really, really good. Often I will use something like fresh, clean water to get the bulk of contamination off. If I need to flush any really sensitive structures, I will use saline, so sodium chloride there. And Chlorhex is really good too. I like Chlorhex. The thing about betadine, so iodine and Chlorhex, remember, don't use them in strengths that are too strong, because in the case of betadine, it will actually be ineffective if it's too strong. And both of them, if you have them too strong, it can be toxic to tissue that you want to keep alive and healthy.
Garnet, can I just repeat that once again, because everyone, are you going more into betadine, or is that your betadine?
Yeah, this is my,
right.
my box.
Half this one on, yeah.
All right. So I want to put a whole slide on here about betadine because I do think it's fantastic. It's one of the best things that you can apply to a wound to reduce the amount of contamination and give the horse the best chance of success. It always comes as a concentrate, so you always need to water it down. It's antiseptic in that it's both antibacterial and antifungal. It's close to being non-toxic as long as you make it really dilute. You still don't put it inside something like a joint, but there's lots of places you can put betadine. And it's pretty much non-painful. Don't get the betadine that comes as an alcohol, but like, you know, you can get those betadine wipes that have alcohol. If you rub that on, that will really, really sting. But it's the alcohol, not so much the betadine. Now, how this is for those of you who like tea, how strong should betadine be when you make it up to use on your horse?
Weak cup of tea.
Weak cup of tea. I think I heard it first from here.
Hopefully I've had a prize.
You've had a prize. Oh, weak cup of tea. All right. Oh, I'm going to show you.
Oh.
It's a tea pot and English breakfast and chamomile tea. Cool. All right. There you go. No worries. Cheers to Bayer or whatever dog food they make. Right.
Can I just ask you a question?
Yep.
Just, what about the surgical scrub one? Where you scrub it
Yeah, it's okay. I won't concentrate better. The idea with the scrub is that action can really break up a lot of dirt and things. So when we scrub an animal for surgery, we'll use the scrub solution because they've often got a lot of dirt in their skin. You want to get all that out. But when I'm cleaning up a wound, I prefer just to concentrate. Okay. Right, and dressings and bandaging, there are so many of them. I just want to give you a couple just so we have a starting point. But I really love Garnett. If you've got a moist wound that you don't want a dressing to adhere to, Garnett's fantastic. So it's petroleum infused gauze. If you just get plain gauze or most bandaging directly on a really horrible wound, it will stick there, which is fine until you need to take it off. And then your horse won't thank you for that. But Garnett will pretty much peel off, which is great, peel off gently. The other thing that's great is Savlon. I use a lot of Savlon in wounds. It is by no means the only cream that I use, but if you just have to pick something to have in a first aid kit, then these two are a really good combination. And then you've got all these different absorbent dressings that you want as your next layer. So up the top here, we have different types of poultice dressings. So who wants to tell me what the word poultice means? Someone up that way. I'm trying to. Yeah, up the back.
Does it mean you draw out?
Yeah, it does. So these fans, do you want a little pong or a big pong? Do you want a bag? I'm pretty sure you can take this to shopping or something. I think this is a cooler bag. Yeah. All right. So. Okay, here we go. So they're really good for drawing out infection and muck and things and absorbing all the things that need to come out of those wounds. This is a very special type of poultice dressing that's hook shaped. So you can put that on the bottom of a horse's hoof. If it's got an injury on the bottom or some sort of abscess, it'll draw out all that bacteria in the abscess. And one of my other really favourite things to use is cotton wool, because you can wrap that around leg wounds, and it'll just keep drawing everything out, and then change your bandage whatever intervals you need to. So they're really good staples to have at the point of care. And then there's some other things. So soft band is this first one here on the left. So that's good if you're trying to wrap a wound that's just small. So cotton wool is great if you've got a big area to cover, but that's great for a small area. Your elastoplast, so that's a 10 centimetre elastoplast, is essential in every horse first aid kit because you need it to hold things in place. And your vet wrap here, so that's your elastic conforming bandage. It's self-adhesive as well, so it sticks to itself and not to the horse. Between all of those products, you can treat 99% of peripheral wounds. And this is just a really quick photo that I found of how to use the cotton wool. So you can wrap around the leg, put some vet wrap around the middle, and then some elastic down the top and bottom, and that'll treat a wide variety of leg wounds that you can have there, at least enough to get them protected so that they're not going to get further contaminated, and then if it's significant enough, pull the vet out and we'll have a squeeze. Also, it's how you change the bandage once we have treated the wound and got it on antibiotics or whatever it needs to be.
So, Garnett,
Yep.
was that cotton wool going directly on wound?
I think this is either an example one or the wounds down there.
That's just an example one, Garnett. Yeah. So normally you'd put a primary dressing on first, like a melanin or some type of swabs, and that's sort of just stuck up there.
Cotton wool's horrible to get out of wounds, so you can pick out little bits of cotton wool. You always need a primary dressing underneath cotton wool. And I'm putting a slide here about the first aid kits because I think these are really awesome little kits. A lot of you already have first aid kits, but if you do need one, Caitlin has designed the West Coast Vet's first aid kit and stocked it with everything super cool that you need to treat, to give first aid to horses. So have a look over there if you haven't had a chance, or you can restock. Okay, so we're up to some example treatments. So what to do with a couple of wounds. I just thought we'd talk through a few ideas. So this one here is a really minor hook location. So you can see here that there's just a little cut. I'll describe it for you. This one is through the skin, but there's tissues underneath the skin affected. So who wants to just throw some ideas? I mean, what are we going to do with this wound?
Purple spray.
Purple spray, yeah, it would. There's a good chance it would get better with purple spray. But what would happen is it would form a really ugly scab, I reckon, for a while, and it may end up with a bit of a scarry defect. But purple spray is good. I do use it all the time. I think it's fantastic. More ideas? What? Yeah. So that would be pretty helpful for that. This is a very fresh wound as well. It's only just happened. So clean it up. Yeah, hose it off, scrub it, clip it. If you've got clippers, just try not to get too much hair in the wound itself. And this one, it was so clean after I clipped it and cleaned it that I actually just closed this with stitches. So that's the wound sutured up there. So I think 1, 2, 3, 4, 5 little sutures in there. And then just put a basic bandage on top with some Garnett. I think I ended up using soft band on this one, and then a bit of vet wrap over the top and then underneath the hoop and some elastoplast to hold it all in place. That one healed up really beautifully. If you can get to these wounds in less than 6 hours and they're really clean and neat, you can close them with stitches. And they will heal much faster and they will heal much cleaner if you can do that.
How long would you leave like the Garnett?
It depends on the amount of exudate coming out of the wound. So usually I would change them first at 24 hours. And then you look at how much muck is in the bandage and you go, oh, that's really clean. You might go for 2 days next time or 3 days. But if you change it that first time and you see, oh, look how much is coming out, you're going to keep poulticing that every day. Okay, tail wounds. So this was really interesting. This is a horse that I went to see that had managed to cut its tail. So it was in a stable at the time, and we looked around trying to figure it out. We think he either did it on a bit of a nail that was sticking out, wasn't very far, or a bit of corrugated iron. But there was just blood everywhere. This one bled a lot. So how would you treat this wound? Just some ideas from the crowd. Yeah, sedate the horse is good. I think I heard clean it up again. Yep. No, I didn't stitch this one. Yeah. And so the reason why I didn't stitch it, it's really jagged, and I think they found it in the morning as well. So it happened a while, but it was still dripping blood. It had been dripping a lot of blood the whole time. It's also, it is a pretty difficult area to stitch. They're a bit sensitive around the back. You'd almost, in the end, this one was actually reasonably superficial, despite nicking a couple of decent vessels. But in this situation, you're not going to do vascular surgery on that. You've got to rely on things like compression and bandaging and that type of thing to allow the blood to clot and the vessels to sort themselves out. So the most important thing to do with this wound was actually to bandage it. And we did, and after a couple of days, it started looking a little bit better. Now, you can see here that there is a little bit of infection here, and the main reason why this one is so prone to infection is what? It's right near the bum. So there's all sorts of bacteria that are going to be all over this one. So it's really important that we use a good antibacterial ointment on there, as well as the bandaging. And that one healed up really beautifully, actually. It healed up really well.
Yeah, if you're using like a firmer compression with that one there, you'd have to monitor it a little bit more often. Yeah?
So you only have that on the first couple of hours, and then you've got a pretty decent clot. And then it'll stop bleeding. But the reason why it hadn't stopped bleeding is just because it's free to flow. So, but horses have lots of blood. How much blood can a horse lose before it's a problem? Lots is a close answer. I would say that a bucket. I didn't hear anyone yell that out, so no one is surprised. But they'll be staggering. So the bucket's about 10 litres. And if you've ever spilled a bucket of blood on the ground, it goes a long way. So try not to panic if you're only this small pool of blood underneath your horse. All right, laceration, large skin flaps. So it's obviously a large skin flap. And some ideas how we're going to treat this one? Yeah, stitching correct. Cut the dead skin. All right. Now I really wanted someone to yell that one out because I wanted to be able to say no, don't do that. So please don't cut these guys off, because the skin, think of it as a biological bandage. It's awesome. You've got the best bandage in the world put back over the top there, and you'll find books and things from a long time ago that say cut these skin flaps off. But there are many instances where these skin flaps are actually viable, and you can suture them back into position. And it's a bit tricky, but we do it all the time. Now, unfortunately, not all of the time do we manage to tell people not to cut the skin flap off. So this is a situation where a skin flap had been cut off. So this is a horse's cannon. Should use my little blue mate here. And it had a skin flap down there that was cut off. Now, the problem with cutting that skin flap off is then you expose things like bone that needs to be covered, because if the bone dries out, it's a big problem. So you've got to manage them as a wet wound and keep them moist. This is Max doing the surgery. You can sort of regrow skin. It's not quite the same as normal skin, but you can develop a functional barrier by actually exposing the area to your bone marrow cells. So what Max is doing here is drilling lots of holes in the front of this bone, so that the bone marrow can actually come out and infiltrate the tissue over the top of the bone and create this pseudo skin over the top. And I didn't get the after photos, but Max has got them somewhere. This horse.
Yeah, that healed really well, and we actually didn't get any sequestrum formation. So a lot of the time when you have these injuries, a lot of that bone dies off, and you get a sequestrum, which is a dead bit of bone. But if you do this osteoschisis procedure where you let all the bone marrow leak out over the cannon there, a lot of them go really well, and they can sort of fully heal those injuries there without the need of doing a skin graft. And just so everyone knows, skin grafting procedures do not work well in horses for a couple of reasons. One, because they've got a different type of blood supply than dogs and cats and humans, and because of the movement of those areas. So over a joint or cannon bone, if they knock it or move it, all those skin grafts die. So never, ever cut off the skin flap. Like, if you take that away tonight, that will make us all very happy, because we can fix a lot of these things if they have got skin to cover. cover the area.
All right, we'll crack right along. So this is the last part of my talk. I just wanted to have a chat about getting help. So if you're in a situation where the horse is stuck somewhere, make sure you get some help. If the horse is lame or has an obvious deformity, something is at the wrong angle or something is obviously broken, get help. Head wounds, pretty much always get help, so call a vet in those circumstances. Or if you've got any signs of infection, I want you to give us a ring, please, so that we can help you. Now, I just want to show some pictures. This is a horse I went out to see that was stuck. So it was found like this in the morning, unfortunately. It had managed to attach itself in a fence. I don't think you can quite see the fence here, but sorry, it wasn't stuck in the fence. It was stuck in the netting from the hay roll. That's it. And it dragged this hay roll across the paddock, pulled down a hole in the fences, and then managed to sort of cast itself here. So it couldn't get back up again because every time it tried, its legs would get stuck on that horizontal bar. Modification for us. And that meant we could get our poor horse up. So up he got, and he was very distressed, but his owners calmed him down, and we got him up and sort of assessed his wounds, and cleaning him off with the hose, just covered in mud. Had wounds just everywhere, poor fellow. I think I used about every bandage I had in my car, just covering, and gave him a drink. He'd been stuck for a while, and just sort of cleaning him up as best we could and bandaged the worst of it before bringing him down to clinic. So just remember there are people who can help, like Rural Fire Stand, if you find yourself in that position. This is the sort of deformity where I want you to give me a ring. So this poor horse actually cut his tongue. So he's cut most of the way through it on the top and about halfway through on the bottom. He really didn't like the look in his mouth, so it was actually easier for me to shove my phone in there and take a video and just try to figure out what was happening. But he came back for surgery, so we did some surgery. Did everyone see it? We're running out of time, so I'll keep going. But we put him back together, so that's him on the table there. He got it caught. Actually, they didn't see it. They found him with his tongue sort of like that, but we think he got it caught somehow. Did they reckon it was the hay net?
Yeah, I think so. They weren't.
We didn't know when I was there. I went out to see him. So, but there you go. That all came together really well. And stitching the tongue is very hard, actually.
Looks very healthy.
No, it wasn't. All right, head wounds. So you can get some pretty severe head wounds in horses, but don't go, oh my god, my horse has a bolt in its brain. It's not necessarily stuff. They have big frontal sinuses, which are these big caverns in the bone, and things like bolts can go into them. I don't mean to make it sound really easy, but we will just pull them out and put them back together. It's okay. It's not in its brain. Not to say it can't go in its brain, but you have to go away. Signs of infection. So I want you to call us if you think that something's infected. So here, this horse has an infected wound up here. And when we ended up just cutting out all that infected tissue, that's how much we ended up cutting out. So unless that infected tissue is cut out, sometimes they'll never just respond to antibiotics. There are lots of infections that antibiotics will clear, but sometimes you actually need to remove all that infected tissue. So your signs of infection there: pain, lameness, heat, redness, discharge, swelling, and odour. Trust your nose. If it smells bad, it probably is. Oh, and now we can have bandaging competition. So I've got a couple of wounds. So the best way to do this is to dob in your mate, because no one wants to suggest themselves to be in a competition. So dob in your mate, and you can potentially win something. Based on how you want to bandage this. So we're going to pretend that our friend Bluey over here has these injuries. Who wants to dob in their mate to do the first one? I think, yeah. And then, now. Yeah. Okay. So you've learned a little bit from our talk. Hopefully, I'll try and move to the side here. What do you think about this wound? Is it mild, moderate, severe? Yep. I agree with you. And is it something that is clean or contaminated? It's not too bad in the grand scheme of things. It's not full of mud and stuff, but it's certainly not sterile, so it's worth cleaning up a bit. And how are you going to classify this wound? Is it an abrasion? Is it a laceration? Yeah, good work. Okay, now using the bandaging material and your trusty vet nurses over there, slash helpers, how would you bandage that? So we're looking at the front right leg, but maybe we just pretend it's front left so everyone can see. I'll just move Bluey back a bit further. And people in the audience can yell out suggestions as well, because that's usually what happens. You're doing it wrong. Okay, what do you want to use first on your wound? So let's say you cleaned it up and now you're just going to use bandaging. Yep. So primary dressing, then melanin. So that's another type of non-stick dressing. So you can put that primarily, and you can borrow your nurses here to hold things. Yep. No, I don't like the wound sprays. I tried a lot of them. I just didn't really find them super effective. You can put so something like that over the top of stitches works really well. Oh, where you can't bandage. Shane's suggestion. Do you mean the ones that advertise that it's like second skin barrier wound spray? Yeah. I've never even heard about aluminium. There's like silver cream. They work well. Sounds like marketing to me. Yeah. Now, one of the other things that I'll say at this point, get all your bandaging ready before you start, because otherwise you'll find yourself going, all right, I've got all my primary dressing. Now I just need that last. So now we can absorb it on this. So we've got some soft band going around there. What a good horse. And so you just want to overlap these a little bit. And when you get to the end of this, you can tuck the soft band back into itself as well, and it'll more or less hold itself up. Yeah, there is. Yeah, so you can use glues to close wounds. However, you want to be very selective about where you do it. So on a horse, I would use glue on a wound on the area that's not going to move the lock against the lock. So if they've got a tiny little scratch up there or something, and you just want to push the skin together, there's something that hadn't gone all the way through.
Hey Garnett, can you just point out there on that bandage, like it's going really well so far, but I just want to point something out.
Yep.
You never want to finish a bandage sort of on a tendon or just above a joint, like on that fetlock there, because Garnett will explain to everyone what a bandage bow is, and you should always either go all the way down to the foot or finish, or go down lower to the joint, because you can get a lot of damage from it. Garnett, do you want to explain what a bandage bow is?
If you stop there, you cause a bit of pressure on the back of the tendons there. So you have your superficial and you have your deep digital flexor tendon there. And if you have that as an area of pressure, then you'll get a bit of edema that builds up below that, and then you'll get swelling of that tissue, and it'll all look really ugly, but then also potentially cause some compression and process in those tendons. If you are in doubt, if you have a severe wound like this, go all the way down to the bottom of the leg. All right, so and then we've got our protective layer on top. So we've done our primary dressing, we've done our absorbent layer, and now we've got some vet wrap on there. And do you want to put anything else on to stop it from falling down? Yep. Well done. And a bit of elastoplast. So Max is super pedantic about bandages, which is really awesome. But don't feel like he's going to come out and go, that bandage is wrong. You know, and we want you to just put on a bandage that's going to be quick and effective. And if you've got a major wound like this, you know, adhere to those principles that we talked about, and then we'll probably go, oh yeah, good work, and we'll chop it off in 10 seconds with a scalpel blade and under all of your handiwork as well. Okay? Yep.
Can you do it too, twice?
Yes, you can. So it's important not to overdo it in terms of tightness. If you want to get a bit of an idea of how tight you should be doing your bandage, practice on yourself. So pretend you put something there and then bandage it on. You want to be a bandage that is, you want to have a bandage that's firm, but if your fingers start tingling, then that's a bit too tight. And that's a really rough way to work it out. If you're not doing horse bandages all day, every day, you need to have something that you can refer back to. All right, great bandage. All right, so that's that wound, and let's go back a little bit. I think that's a pretty good effort. So, what prize do we have? Where's Kate?
There's all the prizes down there, Garnett.
I think. All right, I think Caitlin's going to grab a voucher for you or something like that. Now, this wound. Dob in your mates again. Yeah. Okay. There we go. I think we've had. Yeah. Just there. Come up and do a wound. So nice and quickly, we've got 1 minute. We're going to be speed bandaging because I've gone over time. How do you want to cover this wound up? Yeah. So grab some bandages. So let's do this one.
Just another, sorry I'm sitting up here guys, but just another quick thing. A common thing people ask me is which direction should I have them going towards the inside, but if you think about it, if you are bandaging a horse that tight that you are influencing which way their tendons go, you are doing it way too tight. So just be think about it in your head when you do that. So usually just stick to the same way, but if you are bandaging that tight, you are pulling the tendons in either direction. That's also an incorrect thing to do as well. So I know a lot of people ask me that question.
Right, and so we've gone with a poultice dressing in this circumstance because there is going to be a lot of muck and a lot of infection that comes out of this wound. We want to draw out as much as we can. So this is the sort of wound where a poultice will really excel. We've done the same thing with the primary dressing. The poultice goes on, and then we've got a nice little sort of protective layer over the top. Beautiful. All right. Now, we'll skip past the final one because I've gone a fair bit over time. But the things that I'll just say in my summary is be safe when you're treating these wounds. The horses are anxious and scared. Try whatever you can to prevent any further damage. Take photos and ask for help. All right. And what do we do now? Kaylee, we've got a short intermission again. Did Kate survive? Did Kate get back to the
Yeah, Kate just got back.
Oh, good.
So we'll just give it about another 5 minutes, guys. We know we're a bit over time, so you've got to leave, we understand, but there is another talk on eyes. Caitlin's going to get out the horse that has got all the anatomy drawn on it, visit the trade stands, and if you want to practice your bandaging, you can also do that. So we'll give it another about 5 or 10 minutes and we'll start again.
All right, and there's lots of tricks. Yeah. And subscribe to our YouTube channel.
So guys, when we are doing rectal exams on horses, you can see you can't get in that very far the whole time. Here. So like when we do a rectal exam, I'll go to the you can feel about a third of their abdomen, and it's very dry. Sometimes on farm we go through them, it's not safe to do them, just various reasons. But every time they do it, coming off, we do a rectal examination. And then if we are doing an ultrasound, we can take here on it, and sitting right. And the other thing I wanted to show you was their spinal cord comes down their neck like this. So up here is something called the nuchal ligament. This is nothing to do with the spinal cord up here. This is so they can gallop and dance properly with their spine comes down like this. So whenever you're giving an intramuscular injection, don't jab it right there because that's right into their spinal cord. So yeah, hit it like that. So yeah, you've got to go with this triangle sort of above the spine, shoulder, and nuchal. I am spinning around. Just watch out, guys. Spinning around. So on here, guys, one of the really big things that is different is this thing called the cecum, which is like our appendix. And when we're doing a rectal exam, once again, we might be able to feel this area, and it might be full of gas or have a problem there. But if you get good at listening to horses' intestines, a very, very good indicator whether things are blocked or not is something called the cecal flush, and it actually sounds like a toilet flushing. Yeah, so if you listen to them here, and if you've got time a bit later, I'll get you a stethoscope, you can listen there. It sounds like a toilet flush, and they just flush once or twice a minute. So the cecal on that side is very important. So a lot of the large cohorts sit here. We're just doing a quick raffle, guys. I know a couple of people have to head off for the West Australian Horse Council. So, do you want me to draw this now, Caitlin? You want to explain what we've got there, Caitlin? So, the winner is Christy Unwin.
Oh, yeah!
Yay! Congratulations. You ready, Kate? So there's a couple of prizes still to go here. Kate can just distribute them as she sees fit or not. Depends if he answers them correctly. There's a couple of pongs and toys and we've still got a couple of door prizes. But this is Dr. Kate. If you've been lucky enough to meet her, she's been with us for over a year now, and she's agreed to stay in a lot longer. She's actually going to she's starting a surgical residency program with us, so she's stuck here for a while, yeah? And she has to deal with me. So this is Kate, and she's going to be chatting to you guys about eyes.
So, as we my name's Kate. Can everyone hear me okay? So there's a few familiar faces I will see you again, and for those that haven't met, I know you're probably wondering, but I'm not a third brother. So my doctor is on equine ocular emergencies, including what to do when you find your horse with an abnormality of the eye, and I'll cover kind of a bit of a broad range of things. The bottom line, the best thing to take from this talk is that almost any abnormality, no matter what it is an emergency. And then we'll run through sort of the common conditions that we see, how we diagnose them, and a little bit on how we treat them as well. What went wrong? I'm going to do it sensitively. Watch this, you'll get it first. I just put this slide here because it's when you think of it, horses are like the perfect candidate to get eye injuries. They've got these massive eyes, the size of their head, exposed to everything. And although we love them, I think we all can agree that they can be a little bit crazy. Okay, so say you're on your way to work one morning and you find your horse with an eye like this, with swelling there. Do you need to call us straight away, or can it wait till your day off? Correct. You just never know how serious this could be. And with eyes, they're so fragile and they're so important that calling us straight away, honest to God, could be the difference between saving that eye and losing eyesight. So very, very important to call it straight away. Take the morning off work, just do it. So swelling is only one of the things that you might notice with your horse. These are some more sort of extreme examples. And there is a few spectrum of abnormalities that
that you might see. So redness, there's a conjunctiva there, discharge, nasty laceration, cloudiness, there, a really constricted pupil. So the pupil of a horse should be about this size. Normally, it depends on what kind of light environment they're in, but a horse in a sort of dark, sort of really tiny pupil, that's an indicator there might be something wrong. And again, so these are extreme examples, but anything on this spectrum, these are at the severe end. This is where so you've got us on the phone. What can you do in the meantime to make the visit more successful, prevent any further damage? The best thing is to restrain the horse in some way that they're not going to do any further damage. So often they're sore or they're itchy, and they'll do anything they can to rub their head, and that really fragile eye or whatever they do near them. So get them in a cross tie or hold them, get them somewhere they're not going to irritate further. Avoid manipulation of the eye. So usually a horse with a very small eye will have its stitches very tightly closed. If you force that open, you risk doing further damage. Say that there's splinter under there, if you press that, you might sort of get the eye. Or in really severe cases, horses with really bad corneal ulcers, that eye might be on the brink of a fracture. So if you put pressure there, would be very unfortunate and extreme, but you might actually die. So just leave it and wait till we get there. We've got sedation and nerve blocks to make the examination really easy. Consider a clean fly veil. I say this in caution because a clean fly veil that's sitting off the eye might help in some circumstances if they're light sensitive or if the flies are attracted to the eye. However, a dirty fly veil that's rubbing on the irritated eye might make it worse. So just use your judgment with that. Lavage the eye if there's a chemical injury involved. If you've accidentally put something that shouldn't go in the eye in, lavage it out. So use lots of water to try and flush as much as you can. If you're in an emergency, you can use your clothes to wash the eye out. Now, another really important thing is never put anything in the eye before it's going to see by the vet. The risk here is there are a few circumstances where you might actually, you're trying to do the best thing, but you might make it worse. These two ointments are two that we really commonly use, look pretty similar, don't they? So if you use this ointment in an eye with a corneal ulcer, you risk making it much worse. So if you've got something hanging around in your cupboard from 2 years ago or whatever, just hold off because it might not be the right thing for that particular injury. All right, so we've come to you or you've come to the hospital. It's often much easier if you can to bring the horse into hospital, just because we've got all the facilities here to make the examination really safe and successful and thorough. We'll run through a few of the things that we can do when we get here and how we work out what's coming wrong. One of the first things we do is just observe the horse from afar. So when it walks into the building, we just have a look at how it's interacting in this environment. Can it see properly? Are there any other injuries that we should know about? If it's had some kind of trauma to the eye, is there anything else that we can consider? As well as the facial symmetry and swelling. One of the very first signs of a problem in the eyes is the position of the eyelashes. So this was one of our lovely clients who noticed this earlier in the week. You can see how this eyelash is pointing down, and that eyelash is pointing at a 45-degree angle. So this is a sign of something going wrong. If you pick it up at this point, rather than when the eyes swing to closed, you get a much better chance of a good outcome. Then we might assess the vision and reflexes. So we look at how the horse interacts with the environment. We also perform a test called the Menace response. And this is simple but important. It involves waving your hand at the horse's eye without generating air current and just making sure that they respond to it. So they should close their eyes and move towards it. An interesting thing is that's actually a learned response. So if you do that in newborn foals, they won't close their eyes. And then we'll test some reflexes. So one of them is a particularly light reflex. That's going to be shines light into the eye, and the pupil should constrict in response to that light. If it doesn't, it means there might be a problem with the retina or some of the nerve tracts that supply the eye. Then usually we'll do some sedation and nerve blocks. This is just to make the examination easier and safer. So sedation, we usually use our most common sedatives, might be Zolazine, might be Vitolin, depending on the case. Then the two most common nerve blocks that we perform is the auriculopalpebral nerve block, which stops the upper eyelid blinking. So that means we can open the eye really easily without putting any pressure on the globe or any distractions around. And this one is performed by putting a little bit of local anaesthetic on the skin as the nerve parts of the bone just here. The other one that we commonly do is this one here, this is the orbital nerve block, and that basically reduces sensation in the eye, so it's more comfortable for the pulse. Sometimes we'll also put topical anaesthetic actually into the eye itself. So fluorescein stain, I'm sure you've all seen it before, so it comes in little strips like this, and we use it to try and detect any defect in the cornea. So sometimes we'll dissolve it in a series like this, which will be in the eye. And it's wonderful stuff. So the cornea is made up of 4 different layers. It's got an epithelium on the top, the stromal layer, which is quite thick, and then a descendants membrane, which is here, and then the blood supply layer. So fluorescein stain only stains the stroma here, which means that if we put it into an eye and the eye is normal, it won't stain at all. It will just sit over the it will be brushed off. If we've got an erosion that's down like this, it will stain all those stromal cells, so it comes up with a really bright, glowing green. The other sort of more severe variation of that is that sometimes when the ulcer is really deep, this descendants membrane here actually doesn't take up in the same either. So it'll look like a target, a bullseye. We'll have an area of uptake around, the stroma around the lesion, and then an area in the middle, in the descendants membrane where there's no uptake. And those are the area of it's an example. So this is a corneal ulcer going down to the stromal layer. You see there, it's a full ring. This one is actually another species that I thought it demonstrated really nicely. That's got this green area of uptake, so that's the edge there. In the middle, you've got no uptake, and that's the eye that's at risk of rupture. Okay, so sometimes we'll take examples of the eye. And one that we commonly do is corneal cytology. So essentially we're scraping some cells off the top of the eye, putting them onto a microscope slide.
Press that square again, it'll start. Yeah, I don't know what the Google microscope microphone is.
So anyway, we scrape the cornea, get some of the cells off the surface, put them out onto that microscope slide, and then actually stain them. And when we have a look under the microscope, the different cells of the cornea, as well as bacteria, inflammatory cells, or fungal organisms show up. So this is a case where corneal cytology came in handy. This was an ulcerative keratoconus, so in plain English, a fungal infection of the eye. When we scraped a small section of this cornea and had a look under the microscope, you can see these are all normal corneal epithelial cells there. You can see these branching filaments there. Those are fungal. So we know that when we see this, we need to treat this eye very differently to how we treat the corneal ulcer. The other thing that we might do is to take a swab of the eye, so sample it for bacteria or fungal organisms as well, and send it off to the lab for culture. Okay, so I'll go into a bit on corneal ulcers. Who's had a horse with a corneal ulcer before? You? Okay, that's good. Sorry. Corneal ulcers can range from a tiny scratch to a massive erosion and a huge disaster. And the way that we treat those ulcers along the spectrum is different. So for mild ulcers, this is our approach to treatment, and a mild ulcer is an ulcer just as a stroma at a small area. We'll usually use topical antibiotics, so that will be an ointment put into the eye, and usually that might be, every 3 or 4 hours for 5 to 7 to 10 days, just depending on the ulcer. We also use systemic anti-inflammatories, so that's your Flexin or your Bute, to help it heal, as well as atropine. So one of the most common reasons why the eye is sore when there's inflammation there is a condition called uveitis, and that's where the pupil is very constricted. So a very constricted pupil is actually got some sign of pain. And atropine relaxes the muscle on the it relaxes the muscle that constricts the pupil. So sometimes that might be once a day, depending.
When you treat something like this, would you recommend using a 5-valve?
A clean, well-fitting 5-valve, yeah. Or it depends on the environment. If they're out in a paddock, if they're kept stable, then often, I'm personally going to be normal there whether they help. If you're protecting the eye, giving the anti-inflammatories and you're treating an ulcer, I'd much rather have nothing than a 5-valve that might compromise as well.
The negatives of having a 5-valve on there is you can't see the eye and what's happening with it as well. So there are pros and cons of having a 5-valve.
So when I was with it and I was told to actually sew a cover over the 5-valve over the affected eye.
Yeah. So that's to prevent or to help sort of mitigate photophobia, so light sensitivity, because you're putting atropine and the pupil is quite dilated. Often horses will kind of self-regulate that as well. So, they'll find darker places and it's certainly like, I've had experiences with those and being used as well. I've also been whacked in the face by a horse who they knew I was in the box, but I came on the wrong side with one of those things. So I would hate to tell you to do that and then cause you in trouble, because when they can't see anything, it might be. So with how we judge treatment of a small ulcer is by repeating the fluorescein stain, and that might be in 2 or 3 days time. And treatment length duration is really dictated by how that ulcer is emphasised. Ulcers, the epithelium grows in from the outside in, and it usually grows a couple of millimetres each day. Certainly some can take a lot longer, others and some cases. Trouble with ulcers, some that start small.
Sorry, can you understand that slide? I'm just downloading the presentation. It's pretty weird.
Is that a small ulcer can progress to something much, much worse. So you have to be very vigilant and watch them very closely for any sign of deterioration. And that might be increased cloudiness in the eye. You might actually see the defect get bigger. You might see discharge, either watery or thick and cloudy. You might notice that a pupil that before was quite constricted is now, was quite dilated is now constricted. You might notice that they're squinting more than they were, or sometimes you notice a melting appearance. So those are all signs that straightforward ulcer is getting worse, and we need to do something more about that. We should never just leave them with the same treatment. This is never happening. So, one further step is to intensify our medical treatment, and that might involve the addition of a few different types of medications and treatments. One thing that we commonly do with the trickier cases is using what we call a serum. So this is actually serum that we harvest from the horse itself. Thank you. Yes. Wasn't hired for my technical skills. So autolytic serum, we harvest blood from the horse themselves, spin it down, and then use that to put back into the eye. And essentially that inhibits some of the enzymes that degrade the cornea. We'll also add a few different antibiotics into that mix. And sometimes, if needed, we'll use antifungal treatment as well. Now, often when we're getting to really intensive medical management like this, the eye has to be medicated every 1 or 2 hours, which is obviously very intensive, and the horses can come to resent that if you're continually approaching the eye. So something that we use to help improve that is what's called the subpalpebral lavage system. So this is a little tube that goes from the eye under the bottom eyelid there, comes back, gets looped through the mane, and it has a port at the back here that we use to inject the medication straight under the eyelid. Makes it really easy.
And that would obviously be an inpatient job.
Yes, yeah, usually it's an inpatient. Yeah. The trickiest thing with these is that it just has to be so regular, and so you can leave it here and let us do all that really intensive application of the medication. Even for ulcers that need an ointment, if you're at work all day and you can't do the 6 times a day, you can leave it here. And then if that's not working, in some cases we end up going to surgery on the eye. So there are a few different options depending on the circumstance, but one that I'll talk about we commonly do is something called a conjunctive pedicle graft, and you can kind of think of it as like popping a band-aid on the ulcer, and it provides a whole lot of blood supply and nutrients to help it heal properly.
Is the graft an actual graft or is it an artificial?
Actual graft, yep. So I'll run you through how we do it. Yeah. So this is quite a nasty ulcer. You can see there. You can see the middle is bulging. So that's an eye that could very, very likely rupture without any treatment. So what we do is this is Max debriding the cornea very, very gently. It's very, very fiddly fine work. Then he's undermining the conjunctiva at the top of the eye there, pulling it out like a little flap, and then you translocate it over the ulcer like this, and use really, really, really fine suture to tack it in place, like that.
How does the horse respond with it like that?
Really well, really well. So these cases require obviously medical treatment afterwards as well. We still need to be medicating the eye and frequently there in hospital for a period. The graft, we usually trim it for 6 to 8 weeks after surgery. You can leave them there and we'll just shrink and trim, or we do another chip and sometimes we'll perform what's called a tarsorrhaphy, so that's essentially suturing the eyelids closed to keep that graft safe. Does anyone have any questions about ulceration? So eyelid laceration is another common one that we see getting a lot. A few notes kind of when you first find your horse with an eyelid laceration is to be really careful with what you do to it. So using any kind of disinfectant or antiseptic, you're probably better off just avoiding, because some things can be damaging to the cornea. You can use saline if it's really dirty, but probably better off this way. Don't cut off any tissue or pull anything. Leave it all there, because repairing these lacerations and getting a good cosmetic and functional outcome of that eyelid is really dependent on getting a really good eyelid margin. And if we've lost some of that tissue, it's not going to sit as nicely as it did before, and then you're at risk of secondary also as a result of eyelashes or hair or tissue that shouldn't be touching contact. And so because we have to repair them so precisely, sometimes the general anaesthetic is not needed for these. And you're often better off doing that and doing a really good job than trying and struggling with a horse under sedation. So we do minimal debridement. We try and leave as much tissue there as we can. We get perfect apposition of the eyelid margins there using specific suture patterns. We use absorbable sutures because they're so small and so close to the eye. You don't want to be taking those out. And then we use a sort of general medical treatment program as well, so anti-plaque lotions, ointments. We might use systemic antibiotics, oral or injectable, as well as anti-inflammatories, and making sure their tetanus vaccinations are up to date as well. This is a photo from a textbook on an eyelid that we just left to heal, and you can see the results really is the eyelashes are creating a really terrible ulcer there. So that's why there are emergencies.
No nutrition at all.
No. The last thing I'm just going to touch on, it's a bit of a brief one, is blunt trauma. And this is such a broad subject because it can involve just about anything. Certainly, corneal ulcers and eyelid lacerations can be a result of trauma. But you've also got facial fractures, foreign bodies, perforations of the globe, hemorrhage, sometimes even nerve damage as well. So obviously these are emergency, but I was also just going to mention, if you see your horse get kicked and it all looks okay, or you see them get offence, and even if it looks fine, still recommend getting them checked out, because some of these changes you won't notice until the next day when the eye's really swollen or the cornea has started to erode. All right, and so hopefully you never find yourself with a horse that has one of these issues, but if you do, we can cater to all those needs. So the initial assessment of the horse and diagnosing and deciding on what treatment is required. Medical management, even if you want us to be putting the ointments in hospital, we can do that. We can cover all very intensive management cases is one that we really commonly do. We also do tarsorrhaphies, we do abscesses, we take out third eyelid tumours, and in realistic cases, taking out the whole eye itself.
We do treatment that's required in 2 hours. Is that done at night time as well? You have someone here?
Yeah, round the clock.
Garnett's here to answer any phone call. No, we've got staff here 24/7, guys, so if there's any hourly or half hourly or 5-minute treatments that are needed, they love to.
Does anyone have any questions?
Very good. So, very good. All right, guys. Well, I think that's pretty much it. We're done for this evening there. Thank you. I don't know where Garnett's gone. Garnett was going to organise the door prizes. Caitlin, can you go grab him? He's that way. So once again, thank you for coming. Obviously, if you'd like to see all the trade stands on the way out, we've got that discount on the dental and drenches and things like that if you want to look into that. I've still got a couple of prizes to give away here. So who can tell me a normal horse's heart rate? Well, that was about who's that way? There you go, just right there. Oh, and we've got another column here. What about a temperature? Normal horse's temperature. We'll throw it up that way. And then there's a wormer this way as well. Who answered that one over here? There you go. Good job. Good job. Okay, well, we sort of bounced that. Just we'll sort that one out. We'll see that one out. All right, Garnet. All good, all good. So guys, once again, thank you.
Yeah, so we've got a couple of lucky door prizes, but we figured the fairest way is a short fight to the death. We'll just chuck the ball. Whoever catches the ball can have a prize. So we'll throw once over this way.
So congratulations. This is who's that sponsored? That's from Ram Lab, guys. This is a joint supplement. It's all joint supplement from Ram Lab there. So it's quite an expensive supplement. So congratulations on winning that way. And one over this side, whoever gets it. There you go. So that's the voucher for West Coast Vets for there. So thank you guys, and whoever gets this wins the ball.